My name is Neha Pagidipati. I'm a preventive cardiologist at Duke and an associate editor at JACC. And I'm thrilled to be joined by my colleagues at Brigham and Women's Hospital, Dr. Maria Pabon and Dr. Muthu Vaduganathan, who is also a colleague as a JACC associate editor. Muthu and Maria, welcome. Maybe I could just ask you each to introduce yourselves. Maria, starting with you.
Yeah, Neha, thank you so much for the invitation. I'm Maria Pabon. I'm one of the cardiologists at Brigham and Women's Hospital. I focus my research in heart failure, in many different topics of heart failure, including arrhythmias, but also sex differences in cardiovascular disease, among other interests.
Great. Muthu?
Thank you so much, Neha, for having us. Muthu Vaduganathan. I'm a cardiologist and clinical trialist at Brigham and Women's, and have a deep interest in especially heart failure clinical trials, and was involved in the design and conduct of the Fine Arts heart failure trial.
Well, wonderful, because that's what we're going to talk about today. So we were thrilled to be able to publish your study titled Finerenone Reduces New-Onset Atrial Fibrillation Across the Spectrum of Cardio-Kidney Metabolism, the Fine Heart Pooled Analysis. And we're very excited to kind of get your insights into this study and what this means for clinicians like all of us who are seeing patients on a regular basis. So Maria, maybe I can start with you. Everybody may not be familiar with finerenone and familiar with Fine Heart and the pooled analysis. I think one of the real strengths of this analysis is that you pooled 3 very large, rigorous, randomized trials. Could you just tell us a little bit of background about what those 3 trials were, so what this pooled analysis consists of?
Yeah, absolutely. So so this was a pre-specified participant level pooled analysis of 3 major trials done with finerenone, which is different from MRAs that we can think about. Is a non-steroidal MRA. And so we pooled participants from Fidelio DKD and Figaro DKD, which are 2 trials of diabetic chronic kidney disease. And then Fine Arts HF, which is a trial on patients with heart failure with mildly reduced ejection fraction or preserved ejection fraction. Each trial, so Fidelio DKD had around almost 6,000 patients, Figaro DKD had around 7,000 patients, and then Fine Arts had around 6,000 patients. And so all in all, we pooled over 14,000 participants, excluding the ones that had atrial fibrillation at baseline.
Great. And, I think this analysis is extremely important because, as all of us know, the patients who have cardio-kidney metabolic disease, they have diabetes, they have kidney disease, they have heart failure with preserved ejection fraction, they're exactly the patients who get atrial fibrillation. And then when they get atrial fibrillation, they do so much worse down the line. So I think this is an extremely relevant analysis for clinical practice. Muthu, can you tell us a little bit about what you found, especially in relation to how finerenone impacts the risk of developing new-onset atrial fibrillation in this population?
Absolutely, Neha. And we've talked about different aspects of prevention. We've talked about prevention of various facets of cardiovascular disease, for instance, atherosclerotic disease, even heart failure. But prevention of atrial fibrillation is really a patient-centric goal that's important, that patients, clinicians think about on a regular basis. And so we felt it was particularly important in this trial to adjudicate new onset atrial fibrillation during the trial. And this was collected via a diverse variety of sources by investigators, but was confirmed by electrocardiographic evidence of new onset atrial fibrillation or flutter by a specific team of adjudicators that were blinded to treatment assignment in each of the individual trials. And so this was a rigorously collected endpoint that was harmonized across the 3 trials. And so during the course of about 2 to 3 years average follow-up, the non-steroidal MRA finerenone compared with placebo reduced the risk of new onset atrial fibrillation or flutter by about 17%. And this was robust and statistically significant and consistent across the 3 trials. It was also consistent across other important clinical subgroups, demographic characteristics, as well as the burden of cardio-kidney metabolism. Even those who had overlapping cardio-kidney disease still benefited in terms of reduction in new onset atrial fibrillation flutter. these were very impactful endpoints because they were rigorously ascertained. And once they occurred, as you mentioned, it complicates management and was associated with significant increment in risk thereafter. And there was a steep increase in mortality as well as heart failure events after an episode of new onset atrial fibrillation. So prevention was a key theme and was illustrated with this therapy of finerenone.
And as you mentioned, Muthu, again, one of the true strengths of this analysis, besides the size and just the rigor overall, was the robust clinical event adjudication specifically for atrial fibrillation. Can you speak a little bit to what some of the limitations might be that we should be aware of when we're reading this paper?
Sure, I can start. I think that while we were more certain that the events that were captured were true atrial fibrillation flutter events, we lacked some of the overall capture of these events. And so there's a strong likelihood that we were under ascertaining these events because we did not have systematic rhythm monitoring in these trials. There was no, for instance, protocolized Holter monitoring or short-term rhythm monitoring embedded as a part of these clinical trials. And as such, we required opportunistic screening, that patients either presented with palpitations or routinely screened as a part of clinical care during cardiovascular visits as a part of their follow-up during these trials. And so while the relative risk reductions were substantial, the absolute risk reduction, you might note, is actually fairly modest. And in my view, that might be related to this under-ascertainment of atrial fibrillation or flutter. And if we were to do this in a more protocolized fashion, if we were to fully capture the burden of atrial fibrillation and the onset of atrial fibrillation in these patients, I suspect that burden is much, much higher as we experience in clinical practice. And the absolute risk reductions we might see with a therapy like finerenone might also be more substantial.
Mm-hmm.
Yeah, and in that topic, if I can add something, I think it's obviously important to highlight that we're dealing with a clinical trial population as well, which may not be representative of the general population. And in that population, certain subgroups like Black patients, women were underrepresented. So, highlighting again that we need to do better in recruiting and enrolling patients, different types of patients in our clinical trials. And I think one of the things that I think it's important to clarify in future studies is what is the additional role of MRAs to other potential therapies that can mitigate the new onset of atrial fibrillation, like potentially SGLT2 inhibitors or incretin-based therapies, which unfortunately in our study there were very, very little few patients on them, so we couldn't really assess, the additive role of finerenone in those patients.
Those are great points. Those are excellent points. And as usual, it's not just this program, all cardiovascular programs, we can do better about increasing the representativeness of the population. So that's a common issue throughout. So, we don't usually, I don't usually think of finerenone as an antiarrhythmic, right? So do we have a sense of why finerenone, and I know this is hypothesis, only, but do we have a sense of why finerenone might decrease the risk of new onset atrial fibrillation? And I open that to either of you.
Yeah, I can start. So, so we know from prior studies, there is some suggestion that there is an overactivation of the mineralocorticoid receptor. So, for example, some studies have suggested that the expression of the mineralocorticoid receptor is higher in patients with atrial fibrillation compared to patients in normal sinus rhythm. Also, aldosterone itself, it's known to promote a proarrhythmic state, increasing some calcium currents and the calcium load in the sarcoplasmic reticulum, which can drive arrhythmogenesis. And then lastly, animal studies have suggested that activating the mineralocorticoid receptor can drive inflammation, oxidative stress, fibrosis, and ultimately lead to a proarrhythmic remodeling of the atria.
Great. And, obviously, Muthu, we don't have comparative analyses between finerenone, a nonsteroidal MRA, and, the the more traditionally available MRAs, spironolactone and eplerenone. But there have been prior studies looking at new-onset atrial fibrillation with those agents. Can you give us a little bit of a sense of how those studies compare, understanding that we don't have a direct comparison yet?
Yeah, it's a great question, and just to add related to the last question about mechanism, I think we would be remiss to not also suggest that this also might be just a downstream effect of prevention of heart failure itself, and that prevention of worsening heart failure, which we know was a core mechanism and effect of finerenone in each of these trials, whether in diabetic kidney disease or in people with established heart failure, perhaps that just leads to offloading of the ventricle, perhaps downstream remodeling of the atrium and prevention of arrhythmic events like atrial fibrillation. So that we can't discount, and these are clearly intertwined events, although we consider them sort of distinct entities, but they likely occur in similar individuals. But in terms of your question about comparative evidence, unfortunately, we don't have direct comparative evidence or direct head-to-head trials. But prior trials of steroidal MRAs, such as spironolactone and eplerenone, have evaluated this endpoint. The closest trial to this population was the TOPCAT trial, which of course had significant regional complexity and difficulties in terms of our interpretation of the data. It did not identify a significant reduction in new-onset atrial fibrillation during the course of the trial. In the Americas group, which we think was perhaps more rigorously kind of identified and probably a true finding. But again, this is, atrial fibrillation wasn't adjudicated in the TOPCAT trial. So, and there were differences in other aspects of dosing, conduct of the trial. So perhaps we can't make kind of indirect comparisons there. Preceding trials in heart failure with reduced ejection fraction did identify reduced risk of new-onset atrial fibrillation with the steroidal MRAs. And so, for instance, eplerenone in the Emphasis heart failure trial did show a reduction, and a substantial reduction to a clinically meaningful degree, in new-onset atrial fibrillation. So my own view is that this is likely a MR-mediated effect, that this is central to the mineralocorticoid receptor that Maria had nicely kind of described, and that reducing a hyperaldosterone state, or specifically targeting and reducing the MR overactivation, both systemically as well as cardiac specific, can reduce these types of arrhythmic events. And so we have more data coming up about other types of arrhythmic events in the Fine Arts heart failure trial. And so we hope that will further kind of broaden this kind of our understanding of the effects of MRAs on these types of events.
Well, Maria and Muthu, thank you so much for your time. This was a great contribution to the literature, and especially in our understanding of how to prevent this really kind of significant comorbidity in our patients with CKM syndrome. We were thrilled to publish it in JACC, and thank you for taking the time.
Thank you for the invitation, Neha.
Thank you so much, Neha. And we're so grateful, and we're very proud to be able to publish this in JACC as well.